Welcome to another OrthoPedia webinar. My name is Chris Adams, and on behalf of the Arthrex Global Medical Education team, we'd like to thank you for taking time away from your families to join us. We'd also like to thank you in advance for your participation in this event. So let's get started.
So welcome to the Arthrex OrthoPedia webinar. Today's topic is going to be on degenerative and traumatic meniscus disorders. Before I jump into the program, I want to quickly mention the communication rules. We have some time to answer the questions to our expert surgeons. Please send your questions to our questions@arthrex.de or find the QR code in this webinar. We have at the end time to discuss, but please consider that discussion time is limited. So with that said, I want to introduce our great faculty of today, which is Professor Niemeyer from Germany and Mr. Mark Frame from the UK. Professor Niemeyer is currently head of the knee joint and cartilage surgery at OCM Clinic in Munich. He's well known for his scientific work focusing on tissue engineering of bone and cartilage tissue. Apart from memberships on orthopedic societies, he's currently also having board activities in the DKG and AGA. Secondly, I want to welcome Mr. Mark Frame. He's a Scottish-trained surgeon that currently works at the University Hospital in Southampton in the United Kingdom, which is the major trauma center in the south coast of England. It's a pure knee practice, and he did his fellowship at De Jour in Lyon and also STAR in Dallas. And his special interests are in soft tissue surgery and patellofemoral instability. For the UK surgeons joining this webinar, CPD allocation is provided, and please contact cpd@arthrex.co.uk for these allocations. So with that said, I want to jump into the program and hand over to Professor Niemeyer.
Yeah, thank you very much for the kind introduction, Bert, and thank you to the company Arthrex to join this webinar tonight, and thanks already at this time to Mark to also join this session. So actually, I was asked to talk about degenerative medial meniscus lesions, which is quite a heterogeneous topic, and you actually cannot start this talk without mentioning some really critical studies that came up recently, just questioning the overall indication for arthroscopic partial meniscectomy in degenerative meniscus lesions. And the latest publication on this topic is actually the 5-year data of the Shibone study that have just been published a couple of weeks ago, demonstrating no benefit of arthroscopic partial meniscectomy compared to placebo surgery, which is really remarkable in a follow-up of 5 years. And this study is actually in line with several other studies who compare partial meniscectomy to other active treatments. And nevertheless, we have some concerns about these studies. Most are about the inclusion criteria and the specific patients which have been enrolled in these studies. But nevertheless, we also have learned from these studies, and up to date, we are definitely not that much aggressive recommending arthroscopic surgery in patients with unspecific medial knee pain and degenerative meniscus tears. We have definitely learned that conservative treatment is a treatment option and helps a significant proportion of the patients. And we have also learned to more specifically focus on the symptoms. Sudden onset of symptoms is definitely a prognostic parameter which we consider important when deciding if surgery is important. We have really learned to focus on specific meniscus tests in the preclinical setting, and we also have learned to focus on the type of the lesions. And one type of these degenerative lesions in which I personally feel definitely comfortable recommending partial meniscectomy are these flap tears. Actually, this meniscal grammar sign is described on the MRI, as you can see here on the left image. And this actually leads me to the first case I want to present, which is actually a colleague of mine who presented with a sudden onset medial knee pain, positive meniscus sign. You see this grammar sign here on the right MRI image, as you see here. And this is his arthroscopic video. And in these cases, I feel personally 100% comfortable recommending arthroscopic partial meniscectomy in these flap tears. And at the same time, I don't see any real chance for refixation in these subtype of patients. And interestingly, this is definitely also in line with the ESCA guidelines on degenerative meniscus lesions, which have been published in 2017 and which are really critical about the indication of surgery in general. But what is not really well known is that, again, in this specific guideline, also this grammar sign is actually recommended as one parameter in which still surgery can be recommended and seems beneficial. So the topic of the today's session is what is in my bag, which actually enables me to also give some personal remarks and my personal thoughts about these degenerative lesions. And actually the first statement I want to make is that I personally consider every degenerative meniscus lesion as a warning signal for potential development of osteoarthritis of the knee. And once such lesions occur, the knee is at danger, in my personal opinion. And the risk of OA is definitely not only due to the biomechanical properties of the meniscus, but it's also about biochemical reasons, which will be, in my personal opinion, a hot topic for the next couple of years. And this is actually a very interesting study, which also has been just published a few weeks ago, which demonstrates when we are talking about progression of osteoarthritis following partial meniscectomy, there are interestingly gene expression patterns that predispose for rapid progression of osteoarthritis, while others seem to be associated with no significant correlation for progression of osteoarthritis. And the majority of these marker genes are inflammatory markers. So inflammation is definitely an issue. And this is also in line with a very interesting study, which just also came out a couple of weeks ago, which demonstrates that the use of metformin as a drug also prevents developing of osteoarthritis. And probably the majority of you knows that metformin is also used for diets and weight loss. But the effect of this pharmaceutical in this case also seems to be a biochemical by inhibition of inflammation. So this is definitely something I cannot really talk about more because that's not a surgeon topic, but it will be, and I'm absolutely sure it will be really getting important over the next couple of years. And that's what causes this risk of osteoarthritis and these degenerative lesions on the one hand side, and the other hand is definitely biomechanical overload after these degenerative tears of the medial meniscus. And this biomechanical overload is on the one hand side caused by increased body mass index. Everybody of you is aware that there are many studies out there that demonstrate the efficacy of weight loss and diets in progression of osteoarthritis, but also in pain relief in patients with existent osteoarthritis. This is definitely something you should be aware of when talking about these degenerative lesions. And the second big topic is tibial plateau coverage. So once you have a loss of substance on the other hand side of the meniscus, you lose tibial plateau coverage. And this is something which is definitely strictly correlated with the progression of osteoarthritis. And that's why we are thinking more about refixation and preservation of the meniscus than we did a couple of years ago. And I just want to pick up some topics in this context. And one lesion in which we are more aggressive doing refixation of the meniscus actually is these horizontal tears. In former days, we have treated these tears actually by partial meniscectomy, usually we remove the more unstable part of these horizontal tears. But actually, we have changed our way of treating these lesions completely, maybe since 2 or 3 years, and we are more and more applying sutures in order to stabilize these horizontal tears in order to keep this tibial plateau coverage as best as possible. And there's some scientific data on that which actually prove this concept. Interestingly, the majority of the studies shows that there's no healing of these lesions, or no healing can be proved by the means of MRI, but there's no correlation to clinical outcome with these poor healing in the MRI. And we have long-term data. This is a study evaluating these sutures following horizontal meniscal tears for a period of almost 9 years. And we have proven that there are good clinical outcome can be achieved by these horizontal tears. And nevertheless, there's still a lack of evidence that we can avoid the progression of osteoarthritis. This needs to be added to scientific literature, but I'm personally convinced that this will be proved using this concept for the refixation of horizontal meniscus tears. And the other big problem, which already came on the table recently, but which will probably be even more important within the next couple of years, is a loss of tibial plateau coverage due to extrusion of the medial meniscus. So once the meniscus extrudes, the cartilage is exposed, and this is a high risk factor for osteoarthritis. And again, this is a study from Andrea Achtner here from Munich, and she actually proved, based upon ultrasound investigations, that this also correlates with body mass index. So obesity is definitely a risk factor for medial extrusion. And the same group, actually Lukas Willinger, just published a paper last year, which actually demonstrated a strict correlation between the alignment, varus alignment, and medial meniscus extrusion. And there's quite a bunch of studies who demonstrate malalignment leads to meniscus extrusion, and meniscus extrusion actually leads to osteoarthritis at the end. And to avoid this extrusion of the meniscus is probably the most crucial strategies in order to preserve the knee joint and to avoid progression to osteoarthritis. When we are talking about meniscus extrusion, we are definitely also talking about these degenerative medial root tears, as you can see them here in this video. In contrast to the lateral root tears, the medial root tear is typically a degenerative root tear, though there's no major trauma available in the majority of the cases. Females are more frequently affected than male patients, and there's an association with the varus deformity and varus alignment, actually corresponding to these preclinical data I just have shown by the study of Lukas Willinger. And I personally consider this medial root tear as really a big problem, and this is underlined by several studies. So once we do not apply any treatment for these medial root tear, there's a high risk of these patients to be converted to total knee joints since osteoarthritis progresses in these kind of root tears, probably due to the extrusion. And on the other hand side, once we do a partial meniscectomy in these root tears, which doesn't make sense from any point of view in my personal eyes, there's even a higher rate of consecutive need for arthroplasty, 54% within a 5-year period after diagnosis of these root tears, and that's really remarkable bad. Interestingly, there's a comparable study comparing partial meniscectomy for these root tears and pull-out transosseous or transtibial pull-out repair. And this study actually ends up with a really remarkable observation. Just have a look at the right image, this Kaplan-Meier curve, and you see the survival of the joints, and you definitely see a huge difference between the knee joints that underwent meniscectomy compared to those in which this transtibial pullout was performed. And this has been impressively confirmed by very nice data from the US that have just been published a few years ago, 2 years ago, that demonstrate that refixation of these tears is definitely superior compared to any other treatment, conservative treatment or partial meniscectomy. So this is just a video sequence demonstrating the technique. You see here this degenerative medial root tear, also radial tears within 1 centimeter next to the tibial insertion also are considered root tears, by the way. You see some instability, and how we treat these is we put some sutures into the loose fragment using a meniscus scorpion at this point. We really like to use this fiber tape because it's really easy to sufficiently grab the meniscus using the fiber tape, but also fiber wire is definitely an appropriate option. And the second step of this surgery is to perform a drilling channel, transtibial drilling channel. We use a diameter of 3.5 or 4.5 millimeters in the anatomic insertion. And afterwards, these sutures or the tape is shuttled transtibial, and you can really achieve a good reposition as demonstrated in this video. The tissue is really sufficient even in these degenerative medial root tears, which really allows to pull the posterior horn of the meniscus in the anatomic insertion area. From other preclinical studies, we know that even if we are not talking about traumatic lesions, the healing rates are quite good. So this study actually describes healing rates of approximately 70% in these degenerative lesions, which is, in my personal opinion, concerning the healing rates, a really good relation. This has been demonstrated by second look arthroscopies. Nevertheless, we know about positive prognostic factors and about potential negative prognostic factors when treating these tears. And one of the negative prognostic factors is malalignment. So we really need to be aware that once the patient is also in a varus alignment situation, the likeliness of failure of this transtibial pullout repair is higher, and that is actually when osteotomies come into play. And my personal opinion is actually that you can potentially also treat these meniscal degenerative root tears by an osteotomy only, and this has only been demonstrated by some studies. You actually do not really need to achieve the healing of this root, but good clinical outcome and also prevention of further extrusion can also be provided by the osteotomy only, which I personally consider really powerful tool in these degenerative root tears. And the problem is that sometimes extrusion also occurs without any kind of meniscus repair. This is a video of an extruded meniscus in which partial meniscectomy was performed earlier. And since this was performed really aggressive, actually the tensioning of the meniscus got lost and there was a consecutive extrusion. But we have also these cases in which no partial meniscectomy and no tear is actually visible, but degeneration of the tissue only leads to this extrusion and the loss of tibial plateau coverage. And this is definitely a very interesting pathology, and it's not really good for the joint once the medial compartment cartilage is exposed, and these joints are as well as danger without having any meniscal tear. For that purpose, there are some techniques which have been introduced in order to prevent or to treat meniscal extrusion. This technique, using a refixation on the medial aspects of the tibia plateau, has been published by Paletta, and probably the most powerful technique has been published by the Labrat group last year, and they actually suggest transtibial pull-out repairs extra anatomically in between the pars intermedia and the posterior horn of the medial meniscus. And from a biomechanical point of view, this group was able to prove that meniscus extrusion progression can be prevented by this technique. But again, coming back to the powerful tool of osteotomy, there are some clinical studies already available. This has been published in OGSM this year that demonstrate that using an osteotomy alone, again, is able to reduce medial meniscus extrusion. And this is actually how I treat these meniscus extrusion patients. And this brings me back to what is in my bag. I personally am 100% convinced that osteotomy plates are really a tool which should be in your bag when talking about degenerative medial meniscus lesions associated with varus morphotype. Nevertheless, there are open questions concerning alignment and these degenerative tears. There is the question if you should potentially not perform any medial meniscus surgery without having checked the alignment by radiographs. That's definitely something which is really strict. But I personally do no meniscus reconstruction without a previous alignment check. I personally think that varus morphotype is definitely a risk factor for any kind of medial meniscus reconstruction, especially in degenerated meniscus. And therefore, I claim that it's really important to have the alignment check prior to these surgeries. Nevertheless, the last point I just want to mention at the end of my talk is that biomechanical overload can also be caused by instability of the joint. And when I learned about arthroscopic knee surgery, actually my teacher told me that once you have a longitudinal or bucket handle tear of the medial meniscus, this is always conspicuous for any kind of ACL insufficiency, especially once you have a patient who had already an ACL repair. So you really need to be aware that maybe some remaining instability or rotational instability, which is definitely a separate topic, might contribute to this kind of tear. So once ever you do any kind of refixation for this longitudinal degenerative meniscus tear, have a really close look at the ACL. Nevertheless, I want to show you a video how we treat these. This is more or less a standard technique and gives me the opportunity to also introduce the new fiber stitch, which I have been using for a couple of months. And I'm really convinced by this implant. Here you see this plaque instrument. It's more or less a suture anchor system without plastic anchors. So actually the idea comes from the shoulder, in which these implants have successfully been removed from the anchor systems. And it allows actually you to place a suture anchor system without having this little plastic implants at the basis of the meniscus. That's the one innovation about this instrument. And the second, which I also really appreciate, is that you are able to tension the two sutures independently from each other. So as shown in this video sequence here, by pulling this loop and you are actually able to tension the first suture, and afterwards you release the loop and just pull the remaining cable, and by doing that you can tension the second of the suture, which really enables you to have a good control of these type of horizontal sutures in that case. But again, having these kind of meniscus tear, be aware of potential instability. And the second, and this is more or less also coming to the end of my talk, is that what we also have learned from some latest study is that also when we're talking about ramp lesions, which have clearly been associated with traumatic ACL injuries, these do not only occur in acute ACL injury, but that also chronic ACL instability, and this brings me back to the topic of degenerative meniscus tears, are definitely a risk factor. So once you have any ACL insufficient knees, you should definitely have a close look also at the meniscus ramp, because also this chronic ACL instability is a predisposing factor for ramp lesions. So what we do in any acute ACL injury, to have a look in this intercondylar notch view in order to visualize the posterior medial ramp, I personally believe this is also really important in the chronic ACL deficient knees. And you should also use a standard to visualize the posterior medial compartment also in these knees. And what I want to end up is just to show this ramp repair technique at the end. As you can see, this is not a traumatic lesion. This is more or less a chronic case. Revision ACL 5 years after the initial ACL reconstruction. And what you should definitely do is have a debridement of these lesions at the end, but we actually treat these kind of degenerative ramp lesions similarly to what we are used from the acute injuries. So coming to the end, my major take-home message is that I personally believe that biomechanical reasons for osteoarthritis is definitely something which will help us to treat our patients better in the next couple of years. I personally believe that science will definitely need to focus on that, because progression of osteoarthritis after degenerative meniscus lesion is definitely not only caused by mechanical overload, but on the other hand, we definitely also have to care about concepts to treat this or to avoid this biomechanical overload. And meniscus extrusion is definitely something which I personally consider really interesting. And if varus alignment occurs, and that's really frequent in these patients, I believe that osteotomies is definitely something which contributes to successful meniscus treatment. So thank you very much for your attention. And I can actually immediately overhand to Mark Frame from Great Britain, and he is talking about lateral traumatic meniscus tears. So we are discriminating our talks today not only by the location medial versus lateral, but also by the topic of degenerative versus traumatic. And I'm really excited to hear your talk, Mark.
Thank you very much. Well, that was incredible. That was an incredible amount of data, and that was very, very interesting indeed. So I can't promise quite as much as Philip, and we'll move on with mine. This is probably more familiar territory for a lot of us, and it's a much clearer situation treating traumatic lesions versus treating the degenerative ones. So moving straight into things, obviously, there's a difference between the medial side and the lateral side. It's a different shape, it has a different function, and it's much more mobile. It's a kind of almost a circle, and the roots are very close to each other, and the horns are actually the same size. And the most unique thing that we know is that you've got the popliteus tendon that passes behind, and you've got the popliteal hiatus, and this increasingly has become clear that it's not simply a gap in the connection of the meniscus, and there's specific popliteal meniscal fascicles and ligaments that are very important in control of that meniscus. And we'll go through that a little bit later and explain the relevance of damage to those and how we need to approach them and potentially repair them. So lateral meniscal injuries are very common, longitudinal and vertical tears. Horizontal tears, as mentioned before, tend to be degenerative rather than true traumatic lesions, and are because of microtrauma and this advancement and changes within the elasticity of the collagen within the meniscal tissue. They tend not necessarily to occur in isolation, and just like Philip mentioned, any kind of meniscal injury or a significant meniscal injury, always be very suspicious of something else rotationally abnormal within the knee and the subsequent injury to a ligament, perhaps. The the chances of developing osteoarthritis, again, as mentioned, is significant. And the meniscal repair and fixing your meniscus, which has now become very clear, is it reduces that risk of osteoarthritis and gives patients a much higher level of function and much better patient satisfaction. What's really interesting, though, when doing a literature research was that although it seems to be that the literature supports meniscal repair and people talk a lot about meniscal repair, that actually in practice, there are far fewer meniscuses repaired than are recommended and that are actually repairable. It's not clear why that is. It's whether the tools that we've had up until this point maybe aren't easy to use, or people don't have the experience of doing it. I'm not sure, but that 30% versus 10% is quite significant. So the majority of tears in acutely injured knees, 6% of acutely injured knees have a meniscal tear, 25% of those tend to be lateral, 35% in an unstable knee, so if there's an associated ligament injury. In an acute ACL, interestingly, a lateral tear is much more common. But if you've got that chronicity of an unstable meniscus as mentioned there, it tends to be the medial meniscus that's more impacted. The location of the tear is, from the literature, doesn't appear to have a role in the rate of healing. So that's not talking about the zone of injury, but the location, whether it's the anterior horn or the posterior horn. The zone of the tear clearly has a big impact on the ability of that meniscus to be able to have a healing potential. And that's to do with the blood supply, as we all know, in that small image up at the top, we've seen replicated multiple times, and people understand the red, white, pink representation of those zones. Age, BMI, alignment, they don't necessarily have an impact on healing, and radial tears do much better in all aspects, whether they're repaired versus resection. And that reason is the hoop stresses and restoring the stability of the meniscus and its function. So if we look at the kind of types of meniscal tears that there are and the treatments that are available, we're talking longitudinal tears, which include bucket handle tears, radial tears, the root tears that we've mentioned before, and also this hypermobile lateral meniscus, which I think is to do with an acute injury in a lot of patients. It may just not be as quite an obvious injury, and it's not something that people are necessarily born with. And we'll go through the popliteal meniscal fascicle ruptures and the impact of those. So looking at bucket handle tears to start with, I don't know about everybody else, but I tend to work in the principle of, I have an MRI scan of a patient, I'll go through the MRI scan and I'll try and diagnose what I think is wrong, and then only after that point do I then go and have a look at the report. And if I'm honest, and maybe this is orthopedic arrogance, but I tend to trust my eyes more than the report. But some of the essential things that you need to be able to look for, even if you're not particularly experienced looking at MRIs, are the absent bow tie sign, which is really just that very classical cross-section of the meniscus, both front and back, and it should be very obvious, a well-defined surface, particularly on the T2 imaging, where it should look black. Any fluid that enters in between a tear and the meniscus obviously highlights that as white and should be quite obvious, and is probably the best sequence to look at things. The double ACL sign, so most will have heard the double PCL sign that you tend to have with a medial meniscal tear that's displaced into the notch. With a lateral one, it can often be in front of ACL, and that's something to look at when you're looking at your MRI scan. Again, disproportionately small posterior horn can be quite difficult because your eyes are looking for a meniscus. You can see the meniscus, it may be the shape of the meniscus, it might look quite well defined, but if it doesn't look the right size and volume, then it's important to consider whether there's a more significant injury and that meniscus has been displaced or it's lying somewhere else within the knee. The coronal slices are useful just to have a look at the notch. So the treatment, our aim throughout of all of this is to restore meniscal function, increase the radial tension and the hoop stresses, and the stability of the meniscus. You need to identify the zone and whether it's one that's repairable or whether it's really not. Clearly, if it's at the very tip of the meniscus, it's in that white zone, then repair is not going to do well, and resection is probably the most appropriate thing. Reducing the meniscus and checking for plastic deformation is really important, and it depends on which healthcare system that you work in, how quickly you can get to some of these patients. And if there have been weeks and months, and particularly during COVID, where we've had lockdown and patients have maybe not presented themselves to the service, it's very difficult to look at a large bucket handle tear that would have been repairable, but now that it's been sitting in the wrong place for weeks or months, once you try and reduce that, it's deformed and is no longer going to be able to sit where it should and provide a functional meniscus any longer. It's important to freshen the interface to aid the healing. We need that blood supply to bring all the building blocks of healing to that, and we can use a shaver carefully. And some of the arthritic shavers are particularly good where it's almost completely shrouded so that you're not doing any harm to the surrounding tissues, and you can be very, very accurate in what you're shaving. Or using a needle or a K-wire or something else to trephine and have some bleeding surface to aid your healing. You want to stabilize and compress that interface. So the sutures that you use are really, really important in making sure that the device that you use achieves what you want, because as shown with some of the horizontal tears that Philip was discussing, they may not heal, but if they can support and stabilize the meniscus, they give the patient a positive outcome. So the type of sutures that you use are very, very important. There's lots of different techniques and there's lots of different tools in the armory. There isn't one device that will achieve everything for you. Inside out sutures are very popular, but they can't be used for everything. And you need to have a full understanding and a full skill set to be able to use all the different things at your disposal. You want to try and augment and aid healing, and biologics is something that's discussed, but interestingly, on a literature search, there's really no definitive evidence that adding biologics make a significant difference to meniscal healing, but I'm sure it's one of these things that we just don't fully understand yet, and certainly I can't imagine that adding a biological augmentation to a meniscal repair could be anything other than positive in the long run. Philip touched on it already, but the fiber stitch suture device is been really quite a big change. The fact that there's no longer PEEK implants, there's no plastic that's sitting behind the meniscus is a great addition. It's easy to use, and it's what I've been using recently and think it's been really advantageous. So this is a video of a meniscal repair that I carried out. This was actually using the nanoscope, and if we can play that video.
Reduce this displaced meniscus using the probe. There's a small parrot beak of the meniscus, but it's essentially a red-on-red tear that reduces nicely without any significant plastic deformation. And again, just notice the fantastic view that we've got of everything. We can almost see the entire lateral meniscus. Freshen up the rim, and we use the sharp trocar just to trephine the meniscal capsular junction to encourage healing.
So there was meant to be some audio over that, and I'll just quickly catch up with what's happening. So it's a large bucket handle tear of the meniscus, and we've just reduced that back into the position. There's a small radial element to it that's not all the way through. This is the
meniscal suture needle.
This is the tissue protector as part of the fiber stitch to protect the articular cartilage and aid the passage of the needle. Here you can see the tip of the needle going in loaded with the fiber stitch, and if it just turns round you can see the fiber stitch in there. It's that device at the end that ruckles up and forms an implant that's at the back. So the sharp needle is pushed through the meniscus.
The direction of the common peroneal nerve.
And you've got very good feel. You can feel it passing the meniscus, passing the capsule, allowing you to deploy the implant.
And deploy the fiber
You can
stitch.
adjust the depth of that needle on the device while you're using it.
In the posterior capsule, pulling the needle back into the joint with the next fiber stitch ready to go. Then insert the needle for a second time through the meniscus, through the capsule, and deploy the second fiber stitch, and then pulling the needle back into the joint. You're left with a loop and a long suture. We pull on the loop, which snugs down and cinches the very first suture. And you can see that happening now. And just pulling the meniscus and tensioning it back into the meniscocapsular junction. Then pull the free end of the fiber stitch, just tidy things up, and then finally trim that suture.
So the best thing you can do is to do a good job and do it efficiently with as little trauma to everything else round about. It's going to give you the best patient outcome. You know, the other tools that we've got that can help that I've been using recently, and I do quite a lot of pediatric soft tissue surgery, and that was in a child who was 14, and the ability to use the nanoscope rather than a standard scope is a big difference, particularly getting in between the articular surfaces and being able to protect that cartilage. 2 millimeters versus 6 millimeters is a big deal in children. The other really important instrument, I think, that's changed things is the Zone Navigator, and this is an incredible device to be able to actually allow you to do an inside-out repair, even of the anterior horn of the meniscus, without any trouble at all. So moving on to some other sort of more interesting and slightly different situations. The radial tear is one of these tears that traditionally we would almost universally trim and do a meniscal resection, taking away the corners of the radial tear. But it's clear now that these are amenable to fixation. And the thing that was most difficult for myself to get my head around was repairing a meniscus where you know that it's the white or the pink zones that you're trying to encourage healing. But it's the understanding of returning the circumferential tension and the hoop stresses of the meniscus that's the most important aspect. And that's why repairing a radial tear is important. So even if that white zone doesn't heal, bringing the tension back to the circumference of the meniscus in that red zone where it's near the capsular junction is what you're looking for. And that's where using the meniscal scorpion, which you saw in the last video, or using the Zone Navigator to very carefully place sutures is really important. It's most common in the anterior part of the lateral meniscus, and often the most difficult place for you to try and repair things, and that's where the tools are important. The little ghost there is as a reminder of what's called the ghost meniscal sign, and you see that both with regards to root tears and with radial tears. So again, reviewing your own MRI scans, having a look through, and on the coronal views, you can often have a slice where it looks as if there's no meniscus at all, and that's because your slice intersects exactly where that radial tear is, and that's a clear indicator of what's going on. It's also really important to understand how many millimeters your slices on your scans are, and if it's not a high resolution MRI scan and there's big gaps between the slices, then you have the potential to miss some of these tears. And this is just a picture illustrating a radial tear and using the meniscal scorpion to aid that. It's something that wouldn't be possible otherwise arthroscopically if we didn't have tools like that. So this is kind of going on to look at the other situations and having a meniscal root. These are the sort of things that were coming through clinic recently. So this is not his real name, but James, 35-year-old patient who playing football before all of the lockdown, before coronavirus, had an injury, managed to get over things and felt better in lockdown, didn't really want to do anything with it because he wasn't out and about, wasn't playing football, but did have previously some locking and catching. Now, the MRI scan showed only a very small tear reported. The thought of a meniscal root wasn't really raised. On doing an arthroscopy, it was very clear that he had that loss of circumferential tension and an obvious meniscal root injury. The lateral meniscus is really very important as a secondary stabilizer in the knee after the ACL, and is very commonly part of an ACL injury in that pivot shift type maneuver. It's very important for stability, particularly in deep flexion. Like I said, you've got to have a very high level of suspicion, have a particular musculoskeletal radiologist who's very interested and keen and understands what's going on, and having a high resolution 3 Tesla scanner has been shown in the literature to have a higher rate of identifying these injuries. This is an interesting situation, and I've had multiple patients, and it tends to be sort of adolescent patients who have been passed around lots of different orthopedic surgeons, and have had basically been labelled with having nothing wrong with their knee. Often the MRI scan will look normal. They will describe locking within their joint, often needing their knee to be reduced in the emergency department. And it's very, very difficult to diagnose. And it's been identified that the popliteal hiatus has these popliteal meniscal fascicles or connections to the meniscus that allow it to be more mobile if they're damaged. And it's really a very dynamic problem, and one that you will often really only identify when you've arthroscoped the patient. We had one patient who recurrent episodes coming into the emergency department, needing gas and air, having their knee locked, and it was in deep flexion, and we managed to get her MRI'd with her knee locked because she'd been in 20, 30 times with this, and nobody really believed that she truly had a problem. And we saw that the entire posterior horn of her lateral meniscus was sitting anteriorly, and then once it reduced, looked entirely normal on her MRI scan. These do really very well with repair, and we've been using the fiber stitch for those patients. So that's where I'm going to stop, and we'll hand back to Bert and hopefully have some questions. I certainly have got a few for Philip if nobody else does.
Yeah, thank you, Mark, and thank you, Professor Niemeyer, for these great talks. We in fact have a question from the audience. I hope you can clearly hear me. I have to translate from German, so just a second. Which varus angle, so it's a question to Professor Niemeyer, which varus angle is for you the border for a correction? Würden Sie einen Varus von 2 Grad bei medial starker Degeneration oder Meniskusläsion auch schon korrigieren? So I had to jump into German because my translation skills.
Yeah, this is really a difficult question. We have been talking about in cartilage repair for many, many years, and referring to cartilage repair, we are getting more and more aggressive in order to correct varus malalignment in these patients. And I would answer this with a definite yes in concomitant cartilage surgeries. For meniscus surgeries, I would make the decision individually in dependence of the tear type. So once you have a bucket handle, which is more associated with the chronic instability, I wouldn't be that aggressive with an osteotomy, definitely not. But once you have an extruded meniscus with beginning degeneration, I would think about having a correction in 2 or 3 degrees of varus as well.
Okay, thank you.
Can I ask a quick question? Now, the assumption through all of this has been that the meniscal extrusion is the thing that heralds the degeneration and causes the advancement of osteoarthritis. Is the causality there, or is it that actually they're on a passage to osteoarthritis and the meniscal extrusion is just representing that rather than the cause for that?
Yeah, that's a really interesting question. There are definitely studies who demonstrate that there is an incidence of progression of cartilage damage once initial extrusion occurs. So that's pretty clear in my eyes. I personally believe that once you have an extrusion, there's a tremendous increase of degeneration, but probably also the degeneration supports the extrusion on the other hand side, because the tissue quality probably even in the meniscus changes. So it's a really difficult, and I cannot answer that question with full scientific backup. It's definitely interesting, but for potential treatment option, it actually doesn't matter, because once you have the varus malalignment and the extrusion, it's definitely an issue of unloading. Yeah.
Mm-hmm. And on a really, really simple basis, going back to basic orthopedics, how valuable, because I noticed in one of your slides that you mentioned McMurray's test,
Yeah.
how valuable realistically do you find some of those tests? And as a kind of lead on from that, the ESCA information kind of basically said that X-rays, plain X-rays are the first line and really only moving on to MRI unless there's something else more specific in the degenerative population. Why would we not want more information, and why would you not just do an MRI scan? Why would we reserve that for some special case? So sorry, that's 2 questions. But
yeah, last question. I'm not in line with the ESCA recommendation concerning the indication for MRI. So once a patient presents and I have the suspicion that there might be a meniscus tear, I go pretty early for the MRI. So that's a fact in which I do not follow the ESCA recommendation to full extent. Question number 1. When I talked about specific meniscus tests, I just wanted to point out that this is my major criticism in these studies, because once you have these studies comparing partial meniscectomy to any kind of other treatments, all these studies do not really have strict inclusion criteria concerning specific symptoms for the meniscus, but they mostly include patients with just medial knee pain. And I don't want to point out the McMurray test, but I just want to point out that you should really care about rotational pain and being a little bit more specific than just medial knee pain, as they did in these studies. Yeah. What is your way of indicating MRI? Do you actually use your question suggested that you also go for an early MRI? Is that true?
Yeah, I mean, I have increasingly, I think it's almost universal that I will do an MRI scan on somebody who I think has got significant enough issues that they're in and discussing their knee. I think, you know, an X-ray, even from the perspective of arthroplasty, with the options of partial knee replacements, osteotomy, lots of different things, you know, it seems odd to me to completely, nor would I ever really rely on a plain X-ray. I would almost universally organize an MRI scan, because I just think that there's so much more going on than just looking for a gap. I think that's kind of not representative of where we are now. But.
Yeah, and another argument for an MRI is, since we are indicating meniscus refixation more and more in degenerative tears, we should really know about the type of the tear. So, and we should really know about if the patient maybe is available for refixation on the one hand side, and I cannot judge that without an MRI. Yeah.
So, gentlemen, there is one more question from the audience, also with regards to suturing. Would you suture a degenerative complete radial tear close to the dorsal root, or a complete root lesion if it was an older lesion, older than 6 months? Or would you directly try to reduce the overload with an osteotomy and leave the meniscus alone?
Yeah, so my personal strategy, but I'm also interested in Mark's answer on that, is that we sometimes combine partial meniscectomy with suturing. So if you really have a complete degenerative radial tear, there might be a strategy by just removing the edges of the meniscus and try to tensioning the meniscus rim, because this is something which has really been proven of great importance. So we try somehow to keep the tension of the meniscus, and sometimes side-by-side sutures help to do that. What is your idea about that, Mark?
Well, I think sometimes orthopedic surgeons, maybe German ones are not, but UK ones tend to be very binary, and they make that decision looking at a meniscus whether they are going to resect it or whether they're going to fix it, and the two are exclusive from each other. So as soon as you've picked up the punch to start resecting a meniscus, it doesn't cross somebody else's mind that they could partially stabilize what's left. And interestingly, in my practice, do quite a few kids, and the sort of discoid damaged meniscus did one recently where there was a whole part of the meniscus that was very torn and was not repairable. But then once that was removed, the meniscus was very unstable, although it wasn't torn, and actually combined the partial resection of what was there with the discoid and then repairing it just to restore that kind of circumferential tension. And I think the same thing applies with a root and a degenerate root. I think it should be in the forefront of our minds that we want to preserve as much meniscus as possible, stabilize as much as possible, fix as much as possible, but it's not a binary choice between cutting it out or fixing it. So I think there's scope for both.
Okay, gentlemen, thank you for your lectures, for your presentations, for the questions. It's unfortunate, but we are running out of our time. So I want to thank again in the name of Arthrex. Is there one last question that you would like to raise and discuss?
I also thank you for the invitation. It was a pleasure, and sorry for not staying in time or 100%.
It would be no fun if everybody kept to time. That's fine. My only question is when we can come back to Munich on a plane, but I don't think anybody can answer that one.
Yeah, we're all waiting here in the lab. Okay. Then thank you.
Thank you very much, Bert.
Okay, bye.
Bye.
Thank you once again for joining us for this event. For more information on any of the products or techniques, please contact your local Arthrex representative. You may have also noticed that these webinars are hosted on our new OrthoPedia site. OrthoPedia is an online educational platform of orthopedic videos for you and all your staff. Please spend as much time as you want navigating through the website. It is open 24 hours a day, 7 days a week with no login credentials required. We hope you enjoyed, and as always, we look forward to your feedback about how we can help you treat your patients better.